Yes, Dr. Malini, we can see slides. Yes,
you can see my slides.
Yes. Your voice is clear as well.
Okay.
Thank you, Dr.
Yes. Good job. Okay. So good evening. Hope you all don't sleep off during my talk because it's been a long day, isn't it? Thank you to the organizing committee for inviting me to speak about meningoencephalitis, but I've just changed the topic a little bit to CNS infections. I will be sekejap. Okay. So the outline of my talk, I'll be talking about roots of infection, causative organisms, acute bacterial meningitis, chronic meningitis, fungal, and just a little bit on fungal and parasitic infections, viral encephalitis, and I probably just list down the acute encephalitis syndromes associated with viral encephalitis. I will not be talking about congenital infections, prion diseases, and actually it's such a broad topic that I struggle with how much I'm going to, of information I'm going to give. So probably this is just a brief overview of the common infections of the CNS. So how are infections transmitted to the central nervous system? As you know that our central nervous system is fairly well protected by our meninges. So the most common, perhaps not really the most common lah, but one of the ways is hematogenous. So through the arterial circulation, or even retrograde via a venous spread. Direct implantation, so could be due to trauma, rarely iatrogenic, and I think I don't think we've ever really seen LP causing meningitis or encephalitis or infection, but I think we've probably seen a lot of infected VP shunts and that kind of thing. So that could be another cause. Local extension, so usually it would be either infected tooth or infection of the paranasal sinuses, like mastocytitis, and then ascending infection via the peripheral nervous system, and this is seen in rabies and herpes zoster. So in meningitis, there is infection of the CSF with the arachnoid matter and pia matter. So adjacent gray matter is also inflamed. So this is meningitis. It is not primarily affecting the gray matter or brain parenchyma, but it's actually infection of the protective layer of the brain, which is the meninges. So a lot of organisms can cause meningitis, but I think the most dangerous would be acute bacterial meningitis. And viral meningitis are actually very not very severe and might not need any particular treatment. So classification is such. So what are the organisms causing acute bacterial meningitis? And based on age group, you can see that in the younger age group, it is strep and E. coli that are the most common organisms. So strep from the mother's birth canal, and E. coli also. Subsequently, when they are out of the neonatal age group and less than 3 months, group pre-strep and other bacteria are more common. And up to 3 years of age, I think you see a rising trend of strep pneumonia and Neisseria or meningococcal disease. And then I think in the older age group, it's strep and meningococcal. So the most common causes of aseptic meningitis could be the viruses actually. And then you need to think about non-infective causes, so medications, autoimmune diseases, and neoplasms. Chronic meningitis, I think most commonly perhaps TB, and then you need to think about your other organisms which are, things that we don't really see that often. So what are the symptoms of meningitis? So we have central symptoms, which is quite common and uniform, headache, altered mental status. You can have photophobia, and then, lethargy, weakness, fever. You can have seizures, neck stiffness, and some neurological deficit, but not as common as in encephalitis. So I think the two important signs in to elicit meningeal irritation are the Brudzinski and Koenig sign. And if you are not, you haven't been doing it, so actually it's just having the child lie flat. In Koenig's, you extend the knee, you lift the hip, and then you extend the knee, and the child will have resistance. In Brudzinski, you flex the hips, and you flex the neck, and then the hip and knee will flex in reaction to it, or in response to it. So in newborns and small infants, I think the symptoms might be less clear and more vague. So they might have non-specific fever, poor feeding, vomiting, lethargy, irritability, high-pitched cry, and seizures. So, I mean, if we had seizures, I think our clinical suspicion is quite high, but poor feeding, lethargy, vomiting is very non-specific. So I think you need to have a very high index of suspicion in the younger infants. So acute bacterial meningitis is a very severe life-threatening infection, and it requires prompt diagnosis and urgent specific treatment. And knowing the types of bacteria that infect in certain age groups actually will help. So it is less common than viral meningitis, but of course it is very much more severe, and it has a fairly high mortality rate of up to 15% and a high morbidity rate also. So this is a picture of meningitis, but with inflammation of the meninges. And how do we approach meningitis? So I think approaching any child should be with the initial stabilization of ABC, and then emergency management of any acute issue, meaning if the child is having seizures, maybe you're going to give Mida, Phenytoin, Phenobarb, whatever is needed to stop the seizure. And then identifying any raised ICP, and that also should be managed. Okay, so when would we feel this child needs intensive care monitoring? If the GCS is less than 3, there's any respiratory distress, status, or raised ICP. For our further evaluation, we need to take a focused history and examination, do our biochemical investigation, look for systemic infections. In neonates, we can perform a cranial ultrasound, and in the older children, CT or MRI, and then perform a lumbar puncture if there is no contraindication. So the cornerstone of diagnosis of a bacterial meningitis is CSF examination, and it is classically described as a cloudy purulent CSF with a large number of neutrophils, increased protein, reduced sugar, with or without bacteria on the direct smear. If you have already served your antibiotics, you might not culture anything. However, your sugar and proteins will remain abnormal for quite a long time. So when do we not, when is it contraindicated? So I think even though we do push for LP, we need to be very clear when we should not do LP, when it's contraindicated. So if there is a reduced or fluctuating level of consciousness, and then relative bradycardia or hypertension, so that means there is signs of raised ICP, any focal neurological signs, any abnormal posturing, unequal or unresponsive pupils, papilledema, or Doll's eye reflex, which would have mean that there is some brainstem dysfunction. We generally do not do immediately post seizure. I think although the most of us would wait maybe 24 hours post seizure, but general rule is that the patient is stable post seizure. We will try to not do it in shock and extensive or spreading purpura. So if or local abnormality of the skin overlying. So we will also not do it if we have any coagulation defect. So in a bacterial meningitis, you would have a markedly elevated white cell count, mainly cell count, mainly polymorphs, protein that is also markedly elevated, and low glucose. So so levels for different age groups are actually different. So I think we also need to have a look at the ranges, because neonates actually have a slightly higher threshold of protein in the CSF and even cell count. So neuroimaging, I think cranial ultrasound is only acceptable in neonates. And in fact, cranial ultrasounds can miss a lot. So I think it's very operator dependent, and a lot of times you can miss effusions and other more severe things. A CT scan with contrast, it is very useful to detect complication, and we should do if we have a patient with a prolonged depression of consciousness, prolonged focal or late seizures, focal neurological deficits, enlarging head circumference, or if we suspect a subdural effusion or empyema. So this is an image, a CT brain without contrast and then subsequently with contrast, and you can see diffuse leptomeningeal enhancement. Unfortunately, it's not a very specific sign, leptomeningeal enhancement, and it can be present post-status or in many other conditions. So, just because you have diffuse leptomeningeal enhancement does not really mean in isolation, does not mean this is meningitis. But of course, if you have supporting evidence, then I think it is something that we should take into account. So antimicrobial therapy is organism specific. And of course, I think most of us do use ceftriaxone as our first line, and generally it is going to be able to clear your CSF in most common organisms. But of course, we need to follow our local guidelines for antibiotics. Steroids. So I think NICE guidelines and even the pediatric protocol actually does recommend steroids prior to initiation of antibiotics if we suspect acute bacterial meningitis. Studies regarding the role of steroids have found that it's probably the most useful in Haemophilus influenza meningitis to prevent or reduce incidence of hearing loss. So, your culture is not going to come back immediately. So you can actually empirically or give your steroids if you are quite certain there is a probable bacterial meningitis, and this is indicated by a frankly purulent CSF, a raised CSF white count of more than 1,000 cells per microliter, raised CSF protein of more than 1 gram, and bacteria on the gram stain. So there are a couple of common organisms that cause meningitis, and meningococcal disease, I think worldwide, is still one of the most severe and devastating as well as common ones. Although we very rarely see it in Malaysia, I think it's something that we should know about. So it's caused by Neisseria meningitidis, and it's a gram-negative diplococci. It's carried asymptomatically in up to 20% of the population in the nasopharynx. So it has many strains, so A, B, C, Y, and W125, and different countries have different strain, and it's spread by respiratory droplets. So sorry, I just need to put my phone. Okay. So the clinical features would be that of meningitis. So most meningitis present fairly similarly: fever, headache, muscle ache, sore throat, drowsiness, nausea, vomiting, signs of meningism. But I think fairly specific to meningococcal disease is the hemorrhagic skin rash. So as you can see, this is an image of the meningococcal rash, and I think if you are unfortunate enough to encounter a child with acute illness, fever with this rash, it is acceptable for you to serve antibiotics even in cultures. Or I think classically the GP should be serving the IM penicillin. So it can present as meningitis or meningococcemia, which is just sepsis or sepsis and meningitis. So it has a lot of complication, and I think the one that we read about in medical school is the acute adrenal crisis with the bleed, which is called Waterhouse-Friderichsen syndrome. Antibiotics is with penicillin generally, and I think normal general measures to support raised ICP and an ill child. Vaccine prevention. So I think there are many vaccines available. This is not in our vaccine schedule because it is not all that common in our country. However, unfortunately, I think there are no vaccines that cover all 5 strains. They just cover various vaccine cover various combination of strains. Hemophilus meningitis, and this is something that is very, very rare now, mainly because of our universal vaccination vaccination of infants. And unfortunately, I'm not sure whether in the future we might see more, mainly because of vaccine refusal. So so it can cause severe meningitis in infants, and it's spread by droplets also, respiratory droplets. And treatment is mainly with ceftriaxone. So I think this is probably currently the most common and important organism causing meningitis, Streptococcus pneumonia. Fortunately, we've just started the vaccination program, and hopefully things improve. And we don't see much of strep pneumonia meningitis. So it's a gram-positive organism, and there are more than 100 known serotypes. It is a respiratory virus, and it inhabitates that it stays in our respiratory tract, mainly in the nasopharynx of a healthy person. So actually the carriage rate is quite high in older people and even children, and it spreads via direct respiratory droplets. So it can cause pneumonia, bacteremia, meningitis, otitis media, sinusitis. Systemic complications can include shock, DIVC, and organ failure. There's a high case fatality rate of 8% among children and 22% among adults, and very high incidence of neurological sequelae, including intellectual and behavioral disabilities, seizures, hearing loss, motor deficits in more than 50%. So treatment should be based on the MIC value. I think we start off with CPAN. However, I think based on the resistance, we need to escalate. So in fact, recently we had a pneumococcal meningitis with a resistant strain, and I think this is the first that our ID has seen in Perak. But I think Malacca had 2 cases prior. So perhaps it's becoming more common, the resistant strain, and they are actually severely ill in shock with symptoms of meningitis, status epilepticus, and yeah, so and they probably won't respond to our ceftriaxone alone. So it was fortunate that this young infant, who was around 7 months old at that time, presented to Malacca after prior to this. I think a 1 week prior, there was another kid with similar presentation with resistant strep pneumonia meningitis. So I think the ID physician had a very high index of suspicion and started the vancomycin very early. So the child is fairly well now, but it was a very stormy period. So I think you need to take note of that, and it's not uncommon. So what are the complications of meningitis? Subdural empyema. So subdural empyema should be suspected if you have persistent fever, any infective symptoms, and focal neurological signs. Ventriculitis. So you will have persistent positive CSF culture with no clinical signs, and perhaps even a fairly well child. And our neuroimaging will show enhancement of the ventricular surface and edema of the periventricular white matter. You can have seizures acutely, status epilepticus acutely. Subdural effusion is seen in 20 to 30% of patients with meningitis, and mainly in the frontoparietal regions. These are they can be large with increasing HOC and raised ICP, and these would warrant drainage. However, most subdural effusions associated with meningitis will resolve spontaneously with the treatment of the meningitis itself. Cerebrovascular complications include stroke, venous thrombosis, and intracranial hemorrhages. And patients can develop hydrocephalus early or late. So what are the sequelae of meningitis? So about 10% of children post-meningitis develop sensory neural hearing loss. And this results from the labyrinthitis. So the risk is higher if your CSF glucose was very low at presentation, the patient had seizures before admission, and there is a delayed sterilization of the CSF. It sets in actually quite early in the course, and however, there is a proportion around 20% that have transiently abnormal evoked response. So I think it's recommended that we, if you're going to test early, you should repeat your testing later, because not all of them present early, and there is a proportion that is transiently abnormal but actually normalized later. Seizures, about 2 to 5% actually develop epilepsy later. And these are the children that have associated learning difficulties and other neurological sequelae. So when we manage seizures in these kind of scenarios, so our first, when the patient gets admitted with status or seizures, during the acute infection, we would label this as acute symptomatic epilepsy or seizures, and the treatment is acute management. So you stop the seizures, you may continue some anti-epileptics, but if the child is well and has is fairly unaffected, you can wean off your anti-epileptics after 6 weeks to 3 months, especially if you have no clear neurological deficit. The development of remote symptomatic epilepsy or seizure is actually unaffected by whether you continue your anti-seizure medications or not. And you can't really tell when it's going to happen, meaning it might happen early, it might happen 1 year later, it might happen 2 years later. So it's probably not worth keeping anti-epileptics in the long term when you know that your anti-epileptics were actually started for an acute symptomatic condition that has sort of been well treated and the child is near back to normal. So chronic hydrocephalus is a result of meningeal fibrosis in the basal cistern, and it can be quite insidious in onset, and especially in neonate, we should probably do serial ultrasounds to just watch for hydrocephalus post meningitis. So other sequelae could be hemiparesis, quadriplegia, limb deficits, and actually in meningitis, if the patient survives, probably the deficits is also rare. Chronic meningitis is caused by TB and Cryptococcus, brucellosis, or Treponema pallidum, almost very rarely seen. So I will focus on TB, mainly because I think it is something that is not uncommon in Malaysia, despite our immunization status, we do have a lot of immigrants and migrant workers. So I think TB is fairly prevalent. And generally, a TB meningitis is not primarily from inoculation to the brain. It is there is a primary source somewhere else. It can occur in young children in high prevalent TB areas. In adults, it can happen when there is, even if there is less frequent, it's not in a TB endemic area or whatever. So it has a gradual and onset of generalized illness that can start with malaise, anorexia, apathy, as I think pulmonary TB does, and then progress to photophobia, neck stiffness, and impairment of consciousness. However, on occasion, it can be rapid in onset. So what are the predictive clinical features of CNS TB in children? It has a longer duration of symptoms, more than 5 days. At presentation, you might have a bit a lower GCS, not full GCS, and focal neurological deficit. So actually, this is not specific to TB, it's specific to any brain infection. But I think you need your extracranial markers of disease, so a positive MEN2, any pulmonary TB, and in endemic areas, it is as much as 60%, and a positive history of contact with a patient with TB. So this is caseous necrosis in TB. Okay, so what does TB cause? It can cause meningitis. You can cause CNS tuberculoma. You can have a tuberculous abscess. You can have arachnoiditis or myeloradiculopathy. And you can have tuberculous encephalopathy. So what happens in TB? So assuming we have a primary somewhere, there is hematogenous spread to the brain. So it enters our brain and then migrates and forms a rich focus of infection. And from this rich focus, if this rich focus ruptures, the inflammation and the cells actually release the bacilli into the meninges and CSF, and then that's when you form your exudates, which will lead to hydrocephalus and ischemia infection. So the infection actually generates a lot of inflammation, and everything settles at the base of the brain because the mycobacterium is rather large and heavy. Okay, and then as you know, the base of our brain has our circle of Willis and a lot of the important arteries that actually provides blood supply to most of our brain, and we have vasculitis with of these vessels due to the exudates that settle down there, and vasculitis and thrombosis. This will result in embolization and infarctions, and mainly basal ganglia, cerebral cortex, pons, and cerebellum. Then the blockage of CSF and cranial nerve entrapment can also occur, and then you have hydrocephalus. So common signs will be neck stiffness, apathy, fever, vomiting, drowsiness, headache, and coma. But you can have a lot of cranial nerve involvement because, as I said, it settles down in the base of the skull. So what are the diagnostic tests? CSF examination, of course, xanthochromic with lymphocytic pleocytosis, elevated opening pressure, low glucose, a very, very high protein lah. And then your direct smear might have with Ziel-Nielsen might or might not yield anything, but we should do cultures, and we can do a gene expert of the CSF. So I think another important thing about TB meningitis is if you develop acute hydrocephalus and there has been an EVD inserted and the CSF has been sent, it might not actually yield a culture or much abnormality, because most of the organism has actually settled down in the base. So an LP is actually a more specific or sensitive test for TB meningitis. So if your EVD sample is normal, it does not exclude TB meningitis. Your lumbar puncture sample is actually more specific. So this is the neuroimaging that we see in TB meningitis. So I can see this is the base of the skull where the circle of Willis is, and you can see it is very bright and looks very inflamed, and this is what we call basal enhancement. So this is also basal enhancement on CT scan, contrasted CT scan, you will be able to make it out, and resulting hydrocephalus here. This is neuroimaging showing a right-sided infarct. So CT scan, if we see pre-contrast hyperdensity in the basal cistern, it is very specific to TB meningitis. Of course, you have to have some clinical suspicion also, but basilar enhancement is very sensitive. So post-contrast enhancement in the basilar region, as I've shown here. So it's quite florid. You can't miss it, and I don't think the radiologist can miss it either. A combination of hydrocephalus, infarction, and basilar enhancement is nearly 100% specific. So I think, which is why if we see a child coming in with acute hydrocephalus, which seems infective in origin, you need to think about TB as your differential diagnosis, especially if your neuroimaging shows infarction and basilar enhancement. Meaning, I don't think you need to wait for cultures. You probably need to discuss with the ID team and start treatment. Bilateral basal ganglia infarcts are also something that is common, mainly because of the vasculitis. So tuberculoma is a focal granulomatous inflammation of the brain, and there's caseous necrosis there. It happens mainly in the cerebellum and might need surgical excision. So how do we manage TB meningitis? So of course, supportive care, and then anti-TB therapy, pyridoxine with isoniazid, and treatment is for 12 months. Corticosteroids should be given. And then I don't think we routinely give aspirin, but I think if we have very clear vasculitis and the child has already had a single stroke, we possibly will start. Yeah. So Cryptococcus is rarely seen, and fungal meningitis and Cryptococcus being one of the more common one, and it's seen more in immunosuppressed patients. So you can see that it is transmitted from bird droppings, vegetable and soil, and it can have a very insidious onset. So this image just shows pseudocysts of the brain due to the Cryptococcus. And so there's many. And this is actually our India Inc. image showing the typical encapsulated Cryptococcus neoformans. So I think this is very, very, very uncommon in immunocompetent individuals. And treatment is with antifungal. So other parasitic or protozoan infections are listed, and I will only talk about neurocysticercosis because it is the most common infection, parasitic infection of the CNS worldwide. Perhaps not so common in our country, but it's transmitted by the larval stage of the pork tapeworm, Taenia solium. I think if you look worldwide, it is one of the most common causes of epilepsy, infective causes of epilepsy. It's got a varied presentation, but you can see a really horrible looking neurocysticercosis in the brain. And treatment is with albendazole. So what is a cerebral abscess? It is a collection of pus or dead cells that accumulated in the brain inner cavity. They usually present with some focal neurological sign depending on where the abscess is located. And if there is an intracranial abscess in a child with decreased consciousness, you should refer to the pediatric neurosurgeon immediately. So it can occur anywhere, and it's frequently solitary, but may be multiple. You usually need to think of a some kind of predisposition. I think most commonly we might see in children with cardiac issues, especially those with maybe a TGA or something with direct access without filtration. The blood flow has no filtration in the lung. So this is an image of a cerebral abscess, and this child presented with acute hemiparesis. He had a complex cyanotic heart disease. And you can see a very beautifully ring-enhanced abscess. This abscess needed drainage. So treatment is of course surgical drainage and appropriately extended course of antibiotics. You need to also address the complications, which are raised intracranial pressure, the possibility of brain herniation and rupture of abscess into the ventricles or subarachnoid space. Subdural empyema is a collection of pus in the subdural space, and it's seen more commonly in infants secondary to meningitis. So I think we do tend to do a lot of ultrasound cranium to diagnose, but I think a lot of times we have missed subdural empyemas in infants just via doing ultrasound. So I think if you have a meningitis in a young infant that is with the child not really improving with conventional antibiotics, I think you should probably consider further neuroimaging to look for a subdural empyema. So viral meningitis is more common, but better prognosis, and rarely we can isolate the virus from our CSF. However, I think with now we've got our CSF meningoencephalitis panels that have a lot of PCR tests available. and we are, I think, slowly able to yield a bit better with our viruses and infections. So I think CSF is usually a bit clear and with a bit more lymphocytes and moderately elevated proteins and normal sugar. Okay, so encephalitis. So what is encephalitis? It is the infection of the brain parenchyma itself. So I think meningitis was the layer of the brain, meningeal layer, whereas this is direct infection of the brain itself. It's caused by viruses mainly, and you can have localized or generalized involvement, and can also involve the meninges, and this is when we coin the term meningoencephalitis. Histologically, this is how it looks like. And I think history-wise, we need to have a very thorough history taking. I'm not going to go into very much depth into this because I think this is something that we all know. So what is encephalitis and encephalopathy? So it is a sign of cerebral dysfunction. So what is consciousness? Is a state of awareness of self and environment, and the ability to interact with the appropriate verbal, visual, motor, and psychological response. Whereas in encephalopathy, it's a spectrum of degree of altered consciousness between full consciousness and death, can be acute or insidious on onset. It can involve behavioral change, confusion, and excessive irritability, and can lead to lethargy, coma, and death. This is a spectrum of encephalopathy. So it can be as mild as restlessness and agitation, and can be as severe as comatose. So I think the history-wise, you need to be very clear about signs, history of encephalopathy, and sometimes it can be as subtle as increased sleepiness, sleeping more than normal, and just feeling tired. So it is a very important pediatric emergency, and it can involve children of all ages. So we need to appropriately manage. So a neurological examination should be done in all children with suspected encephalitis. I'm not going to go into depth. So I think different viruses, how do we identify or at least sort of have an inclination towards what organism we are dealing with based on site of involvement. So a lot of the flaviviruses like our basal ganglia and thalamus, and this would be Japanese encephalitis, dengue encephalitis. The anterior horn cells, so of course polio classically, but because of our immunization, we don't see polio, but another common thing would be EV71. Frontal and temporal lobe by herpes simplex. Brainstem, EV71 again. Cerebellum by varicella zoster, and ventriculitis, CMV, varicella, HIV. So herpes encephalitis is commonly caused by HSV type 1, and it presents abruptly in a previously healthy individual. So it will present with classical symptoms of encephalitis, so fever, seizures, lethargy, decreased conscious level. But it affects the temporal and inferior temporal lobe, and can cause very severe encephalitis. So you can see this is the inferior frontal lobe, and this is the temporal lobe, and you can see very abnormal T2 signal intensity. So how a lot of times in herpes, we get, in a child that presents to us with encephalopathy, we are quite sure this is infective in nature. We will start acyclovir, which will be treating our herpes simplex encephalitis. Other things that would help us, be sure would be, of course, the area of involvement, and if the child has frequent clinical focal seizures, any focal neurological deficit, especially hemiparesis or hemiplegia, and there is an EEG finding called uh, uh, periodic lateralized epileptiform discharges. So you can see that I think this is a AEEG bedside, and you can see just abnormal periodic shock waves in one area and on one side of the brain. And when the neurologist sees this, we feel that this is also very suggestive of herpes, and we generally will work up for herpes encephalitis. Of course, any focal lesion can cause this, but if you are thinking of infection, the first infection we would think of is herpes encephalitis. So when do we suspect? If we have focal neurological signs, a fluctuating conscious level, previous contact with or hepatic lesions, prolonged convulsions with no precipitating cause, no other cause, or we should treat for herpes encephalitis. So dengue encephalitis, dengue can cause encephalitis without our systemic symptoms. So you don't need to be in dengue shock or dengue hemorrhagic shock in order to have dengue encephalitis. It's seen in about 5% of infection, and mortality is about 8%. In the early phase, you can just have headache, high mean temperature. It can be associated with dengue hemorrhagic fever, low platelet, high hematocrit, and abnormal liver function, so very non-specific. Neural imaging, as you see, flaviviruses like our basal ganglia. So this has a bilateral basal ganglia abnormality, and some abnormality in the internal capsule. CSF findings would have dengue IgM or NS1 positive.
Sorry, Dr. Malini, to interrupt. We have around 5 more minutes left.
5 more minutes?
Yeah. Sorry. Sure. Thank you, Dr. Malini. Sorry for the interruption.
I think a bit late lah, but never mind. Okay. So the other important encephalitis is JE, and so JE is circulated among water birds and pigs, and it's transmitted by the Culex mosquito to humans. So humans are actually not an amplifying host, we are an end host. So there's no human to human transmission. It starts off with a febrile illness with or without subsequent encephalitis. I think importantly, a natural history of JE encephalitis, incubation period of 5 to 15 days. Then you might have subsequent high-grade fever, headache, and vomiting. A drop in conscious level, seizures, upper motor neuron signs, flaccid paralysis, focal neurological signs, or abnormal behavior in older children. And then subsequently, this is maybe second week or third week, you might have sort of these Parkinsonian features of mask-like faces, tremors, dystonia, choreatetosis. And then you have some patients going into recovery and improvement, but occasionally we have a biphasic sort of pattern where the patient improves and then worsens again with a lot of movement disorder. It can sometimes be associated with Guillain-Barré or NMDAR. And we have finally neurological, cognitive, and psychiatric sequelae. So these are the investigations. I think importantly, the PCR positivity is very brief. So if you have a negative PCR, does not mean that you don't have JE. If you have a high clinical suspicion of JE, you should do your CSF IgM. And in fact, if your first CSF IgM is negative, you should repeat it. This is if you have a high index of suspicion. Okay, so this is neuroimaging of JE, and you can see bilateral basal ganglia involvement. This is substantia nigra. So it's all the areas that are involved in movement. And here again, sorry, that was thalamus. This is basal ganglia. And again, the substantia nigra. So treatment would be with Artane, clonazepam, baclofen, dopamine, whatever you can do. Unfortunately, a lot of times the dystonia is refractory, and a large proportion have lasting neurological deficits, fairly severe. So the vaccine is not in our immunization schedule, but you can get it outside. I'll skip CMV, but I think I'll just touch on EV71. So EV71 is classically seen in hand, foot, and mouth disease. So it's fairly common, and we do have outbreaks on and off. There's four stages. So the first stage would be just the lesions, the hyperangina. And then a small proportion actually move on to stage 2, 3, and 4. So the CNS involvement is stage 2, and these actually appear within 3 to 5 days of onset of the fever and the skin lesion. Sometimes they show the neurological manifestation are seen without the skin manifestation or oral mucosa manifestation. So there are many presentation, and I will just touch on 3 common one. So brainstem encephalitis, which is the most devastating and with high mortality, and it's characterized by myoclonus, ataxia nystagmus, bulbar palsy, with or without confirmation of neuroimaging and a virus isolation. So you can see this is the medulla, and the posterior medulla is involved. This is the midbrain, the pons and the dentate nuclei being involved. So I think the devastating consequence would be autonomic dysfunction and leading to our neurogenic pulmonary edema, and most patients die of neurogenic pulmonary edema when they develop brainstem encephalitis. Aseptic meningitis, not very severe, and just presents with very non-specific symptoms. The other very important manifestation is acute flaccid paralysis, and it is like a polio-like presentation. And I think it's perhaps not that clear, but you can see subtle hyperintensity here at the anterior horn cell on the left side of the spinal cord, and this child presented with acute left upper limb monoparesis, motor involvement alone with sensory completely spared. So that's classical of acute flaccid paralysis. It does not respond very well to treatment. We try IVIG, steroid to try and shrink the surrounding edema, but child had no response, and I think I've seen most children have no response. And then there's COVID-19 related neurological complications, and there's a lot. I think I will just skip this. And then I think post-viral infections, I think we have a lot of post-viral encephalopathy syndromes like AES, MERS, IBSN, and NEC, and HHE, or yeah. So my take-home message would be, I think I think you still need to focus on your history taking and clinical examination with identification of neurological manifestation. Your management should always be acute and symptomatic, meaning ABC, symptomatic control of seizures, and then definitive treatment. And please do not miss out on the complications, because a large proportion of these patients have lasting neurological deficits. Thank you.
Thank you very much, Dr. Malini. Actually, I have a question here. Is steroid actually routinely suggested to be given in bacterial meningitis?
So the studies say in high income countries, it should be given. So I think we are not really high income country. However, our PEDS protocol does mention that if you are sure this is acute bacterial meningitis, please go ahead and serve your steroids. As I said, I think I gave you the criteria of acute bacterial meningitis, means you don't have your culture yet, but clearly your CSF is purulent, you have got other signs to suggest this is bacterial meningitis, you should serve your steroids. I think it's something that we not I don't know, we seem to have lost the practice, but it's still mentioned in all protocols.
Thank you, Dr. Malini, for the answer.
Dr. Malini, hi, thank you for the lecture.
Yes.
I have a question as well. You were talking about cerebral abscess, right?
Yeah.
Regarding that, I noticed like certain respiratory teams and everything like Empayema, they started to move away from surgical intervention and rely solely on antibiotic therapy. So in the setting of a cerebral abscess, how do we determine whether what kind of cases require surgical intervention per se, and what cases can we have a trial of antibiotic therapy first before going into surgical intervention?
Interesting. I'm not sure whether I'm the expert to answer. However, I think based on my experience, we always try antibiotic first, but we always monitor serially. So in the case that I've seen drainage for, it was a non-resolving and non-improving abscess. Because I think depending on the site, if it's very deeply located, the drainage is not simple. It is not as simple as just opening it up and draining it. It's not as simple as the lung. It is very complicated. They need special devices. Patient will have to buy something to stereotactically find the location. So the patient that ended up, the image I showed you that had a drainage, that child had to be sent to KL for drainage. So it's not actually very easy. So I think generally we do give antibiotics and see whether we are shrinking it lah. But however, I think oftentimes we might not completely, the abscess might not completely resolve, and then we will need to drain somehow.
Thank you, Doctor.
Thank you.
There's another question in the chat box. I can't wait. Can you read it? I can't seem to.
Child suspected to have TB meningitis if the TB gene expert from LP sampling is negative. Does this mean the TB meningitis is very unlikely?
This is what the ID told me lah. Because it's PCR, it should pick up lah. It should pick up. But yeah, so I suppose it is. However, if you really do have the triad of, acute hydrocephalus, and this is a child with, exposure to TB, and there is vasculitis, basal exudates. If you sent your EVD sample, it might be negative lah. is your LP sample that is more positive, this one, but yeah, I think this one will be a very complex discussion between ID and whoever's managing the child about whether we would continue or not lah, manage treatment. But yeah, I'm not very clear, but I know that it is actually very, very, very sensitive lah, gene expert. So it should be positive if you have TB meningitis. But I think it is not the most sensitive. There are way more sensitive tests out there. Just that in Malaysia, I think probably Gene Expert is the best we have.
Okay, thank you, Dr. Malini. Thank you so much. So I think because due to the time, we really we are grateful for your talk, Dr. Malini, for your informative information on CNS infections. I think you have covered a lot and then have cleared off our doubts very much. So now we shall move on to quiz for the topics today. So okay, so